hope if you can fill these out, leave them at the back. Feel free to grab some food and take some questions.
Yes.
Oh, thanks for putting that together. It was really great. We looked at surgical resections and found very few, if any, patients that just had the fibrotic burnt out stricture. That if that exists at all, it's very rare, and
Right.
most patients have inflammation ongoing. I wondered, in your pilot study of 11 patients, did you look at those resected specimens, and were there any predictive markers in the histology itself, or did Rick come up with anything on the genetics of those patients or other biomarkers that might add to the
Right.
mix?
Yeah, so we actually looked at, so I don't have enough to say definitively, so I get worried answering that question that people are going to take this, but the IL-23 seemed, the receptor seemed that and NOD2 seemed to predict some of the high rates of recurrence. From a pathologic standpoint, again, not that we selected, but all but 2 of these patients actually had penetrating disease. Histopathologically had the highest scores from an inflammatory standpoint. So we didn't see much there. Clearly, if we were to look at, and we found in our NIDDK consortium, and I agree completely, only 9%, if that, have fibrotic-only disease after many years. That's a very rare case. I think phenotypically and genotypically, that's probably even a subset that's not really Crohn's. To be quite honest, I think that that's something completely different. And there are actually, that group is being looked at in the GWAS data right now and is probably something very, very different. We don't have enough yet, though, from a marker standpoint, and the geneticists always hate when we present 24-patient studies because they like to see 20,000 patients before we can say anything. So I wouldn't take anything away from that. Yes?
Is a ileocolonoscopy enough for postoperative surveillance of recurrence? Meaning, do you do anything from above, or do you do axial imaging to look for more proximal disease?
Yeah, I mean, that's a very good question. We have not, to this point, done that. Now, the patients who are in this study had prior imaging of the small bowel, whether it be in our institution, CT enterography, small bowel follow-through. Actually, a couple of them came from Children's, where they're doing a lot of MR enterography. I think 4 of the patients had a video pill capsule at some point. Routinely postoperatively, though, we're not searching elsewhere to look for lesions. One of the things our surgeons are actually now doing, though, at the time of surgery is they're doing more small bowel dredging to see if we're missing occult webs or strictures. We're not picking up a high rate, but we do pick up some patients who they went in for an ileocecal resection and they found a skip area that didn't show up on any radiographic, or actually even with video pill, it didn't show up on a video pill, but we're not routinely doing that. I'm interested in seeing ultimately if ultrasound or other imaging modalities, especially non-invasive, if we can look at this, and not even for post-op. This is for all Crohn's disease. Yes?
How readily have your surgeons adapted to this practice of starting with anti-TNF agent within 4 weeks? The reason I ask is I have personal experience here on our IBD consult service. I actually had a patient of Tim's that we actually cited your paper in our note, and they
weren't very happy.
They're waiting for the PREVENT trial results. They want you to enroll the patient.
They want a full 4 weeks.
Yeah. You're right, it might be cultural differences. Our surgeons have had no problem, and maybe because we've worked, now it's been 12 years where we have joint clinics working together, they become comfortable with this. They were part of this and saw this, and actually, you know, it's interesting, and I'll tell you a caveat, and I was shocked the other day when I saw this, but one of our surgeons started a patient on anti-TNF. That blew me away. Actually, I had to sit down and talk to him that probably we should be the ones doing that. But and that wasn't even a post-op patient. That was just somebody who was seen prior to doing an operation. So you're right. Different institutions, when I go around and have this, there's some concern about this. We haven't seen this, and then we have more numbers just from a clinical practice standpoint. I think we have close to 72 patients who we've adopted this strategy. Now we're putting them in PREVENT, and we haven't seen any problems with wound healing, infection. We use the 2-week post-op visit, though. If they have any sign of infection, complications, we do not put them on an anti-TNF at that point. But most of them do, actually most of them do very well.
Looking at patients pre and post initiation of whatever therapy you decide to use, do you find that there's an incremental benefit as you get further endoscopic improvement?
or is it just whatever their baseline endoscopic score is that's what's most predictive of their course?
Meaning, can you downgrade a score of a 4 to a 1 and then set the clock again?
Or if you go from an I3 to an I2.
Oh, I see.
Is that enough, or do you need to
Yeah,
get down
and we don't know. Again, the Belgian group has looked at this the most, and based on their data, it seems that if you're in those higher scores and downgrade from a 4 to a 2, a 3 to a 2, probably doesn't make a difference, and again, probably has to do with more what's happening under the surface. So again, Dave Binion is now making a career looking at the vascular part of these patients, and some of these patients are having vascular changes that probably leads to some ischemic changes, which lead to more scarring. I think when it's too late, it's hard to recover. Nonetheless, we all have patients with ulcerative colitis who we put on an anti-TNF, and years later, or even a 5-ASA, and we can't tell they've ever had disease before, and we look back and say, did they really have IBD? I think that's a little rare with Crohn's, but we certainly have some of those as well. But downgrading a little bit probably doesn't make a difference, but we don't have any long-term data yet.